I was supposed to talk to you about hematopoietic stem cell transplantation for Wiskott, and the fact that there are some people in the room who know very well what a stem cell transplant is, and some people probably don't. I kind of split this into two parts. So in my first part, I will actually explain a few basic things about stem cell transplantation as good as I can. And then I will focus on the Wiskott-specific data that we have and don't have. So the general concept of a stem cell transplantation always, no matter why you do it, is the destruction of the recipient hematopoietic stem cells which reside in the bone marrow and the corresponding immune system that is produced by these cells. And you destroy this by something that we call conditioning, which is usually cytotoxic chemotherapy, and I'll come back to that. Then you transfuse hematopoietic stem cells of a healthy allogeneic donor, meaning that would be another human being. And by this, you replace the defective stem cells and the complete hematopoietic system with all healthy cell lineage in an optimal scenario. So all the white blood cells, all the red blood cells, all the platelets, and the entire immune system by that would be of donor origin and be healthy by definition. There's three different basic sources where we can get these stem cells from. We can harvest them from the bone marrow, which would be done under general anesthesia, as it is quite painful, and you need quite a bit, actually. Or you could harvest them from the peripheral blood, so-called apheresis procedure, where the donor undergoes a 5-day stimulation with a drug called filgrastim, which mobilizes the stem cells from the bone marrow into the blood, and they can then be collected via a procedure where the blood is taken from one arm, goes into this machine, and then the white blood cells are extracted, and the rest of the blood goes back into the other arm, back into the donor. And these are two very good options. The third one is a special one. As you all know, umbilical cord blood contains a relatively high number of stem cells as well. So the blood that is remaining in the fetal part of the cord blood can be collected. It's usually about 80 mils or 100 mils, and then these cells can be frozen and stored at minus 170 degrees and used for a transplant for a different person sometime later. As for transplant, it is very important that you choose the right donor. You cannot perform a transplant from any donor, and it's very important that you mix the most compatible donor with his recipient, as in this cartoon. And that we determine whether a donor is compatible or not by looking at the HLA system. HLA stands for human leukocyte antigens. These are antigens that were first described in the 1950s because in the blood of pregnant women one could find antibodies against other white blood cells, in this case against white blood cells of their children. And these HLA antigens, which are present on any human tissue, determine whether an immune system can detect this tissue as foreign or self, and therefore they determine tissue compatibility. The problem with, or the good thing with HLA is that it's extremely variable between individuals, and all the HLA genes are located on chromosome 6, and there's a number of them which are grouped into 3 classes. But for transplant, or for stem cell transplant, we only look at 5 of those, and everybody of us has 2 copies of each gene. So as a total, we would look at 10 so-called alleles, which are important for stem cell transplantation. And this will also lead to, I don't know if it is working. This will also lead to this designation of the degree of match. For example, if someone is identical in all these 10 alleles, he would be called a 10 out of 10 match, or respectively, if you tested fewer, like for example 8 or 6, you would call someone in 6 out of 6 or 7 out of 8 or whatever match, depending on how many of these alleles would actually be identical. This graph here shows the number of known HLA alleles. So this is an ongoing process, and every year there's a number of new alleles being discovered, just describing the extreme variability of this within mankind, really. And this also illustrates why sometimes it can be very difficult for a person to find an unrelated identical donor because their HLA type is very rare. While on the other hand, for some patients, it's very easy to find hundreds of potential donors because they have a very frequent HLA combination. And the other thing that is important for you to know is, and I think you do know, that every person has chromosome 6, and one of these chromosomes, if a couple has children, one of those chromosomes comes from the father and the other one comes from the mother. So in theory, there are 4 different combinations possible in every child, and therefore for each sibling, the chance to be HLA identical would be 25%. These are the different types of donors that we use in stem cell transplant, and I've put down also the abbreviations that we use for them, so it makes it easier for you to read the data that I will present and that you may have seen elsewhere. So the oldest and most popular donor is the matched sibling donor, or MSD, and as I said before, there's a 25% chance of a sibling to be identical. The next one, which is much rarer, is the matched family donors. So in some families where maybe the 2 parents share a very common HLA type to some degree, it is possible that a child is also identical, for example, to his parent or to some other relative. This is a relatively rare occasion, but it does occur every now and then, which is why we always recommend to not only test the patient but also HLA type at least the parents, and if there's some commonality or very frequent alleles, we also suggest to maybe type some uncles, aunts, or whoever is possible, but this is a rare occasion. The other more frequently used and most frequently used type of donor is the matched unrelated donor. You know that there is a worldwide registry, or actually it's multiple registry that are interconnected, where people have registered themselves who are willing to donate their stem cells for any unrelated person somewhere else in the world who, by sheer coincidence, shares their HLA typing. So if we have, as I said before, we look at 10 alleles. If all these 10 are identical, we will speak of a matched unrelated donor, 10 out of 10. Sometimes there is a difference in one of those alleles, then we would call that a 9 out of 10 match. But here the terminology is not consistent. Some centers would call that a matched unrelated donor also. Other centers would call it a mismatched unrelated donor. So it's very, if you read that, you always need to keep in mind, it's better to know the exact degree of match to decide what we're actually talking about. I'll try to do so later in this talk. A fourth option that we have already touched upon today is a so-called mismatched family donor, or MMFD, or haploidentical donor. So haplo stands for half. So by definition, since everybody of us has inherited their HLA half from his father and half from his mother, the mother or the father is always at least half identical to their child. So usually they would be a 5 out of 10 match. Sometimes there could be some commonality by coincidence. It could also be a 6 of 10 or 7 out of 10 match, but we would still call that a haploidentical donor. And then there's unrelated cord blood. You know that these cord blood stem cells are being banked throughout the world to a lesser degree these days. And for these, a lesser degree of HLA matching is required to have a good matching situation. So, for example, one could look for a 6 out of 6 or 8 out of 8 matched cord blood donor, unrelated cord blood donor, which would also be a very good unrelated donor. However, with cord blood, there's always issues of cell number because the absolute number of cord blood stem cells is relatively low in these preparations. So you not only need to find a match, but it also has to have a good amount of cells. So the degree of immunological match goes down in this direction, and with the degree of immunological match in a reverse manner, we have a correlation with the risk for graft versus host disease or rejection, at least in theory, because the more different a donor is to his recipient, the more frequent we would have complications that involve either of the two immune systems attacking the other person or the other cells. So for conditioning, as I said, these days we use cytotoxic drugs or chemotherapy. We could also use irradiation, and we still do that for some patients with leukemia, but generally for diseases like Wiskott, this is not done anymore because of long-term side effects. And 2 years ago, Dr. Pai from Boston, who I believe will also be in this room tomorrow, gave this talk, and she used this very nice metaphor of comparing a stem cell transplant to a garden being redone. So what the conditioning does, it basically plows out all the weed and stuff that's not wanted, and the result of that is the bare ground. So that's what the conditioning does, and I will continue to use this metaphor. And actually, I am still, I am now using it for all my consults since 2 years ago. So thanks, thanks to Dr. Pai for that, because it's very fitting in many ways. So for chemotherapy, we usually pick out a combination of either these three drugs, busulfan, treosulfan, melphalan, because they are the ones that are mainly responsible for killing the recipient stem cells, and one of the other two drugs, fludarabine or cyclophosphamide, because they're mainly responsible for killing the immune system of the recipient. And then we usually combine this with so-called serotherapy or antibodies that are used to target the recipient immune system and have become quite important for transplant. So for example, we would pick up a combination of these three, and that would make up the conditioning regimen. Transplant is a complicated procedure. It's not a surgery, by the way, just to point that out, because we've heard that previously. It's a transfusion of cells. It's not a surgery, but it does have complications. It's a very intensive procedure, and there we need to kind of separate between early complications, early toxicities, and late toxicities, and I've tried to put up the most important ones here without going into very much detail. So early toxicities could be or will be mucositis, which is a direct toxicity of the chemotherapy and will occur about 2 to 3 weeks, for about 2 to 3 weeks right after the chemotherapy, meaning that the mouth could become painful, and same goes for stomach and gut, and children are sometimes or usually not able to eat for themselves, so they need feeding via their central venous line. Also, the conditioning will result in a very severe immunodeficiency state because the recipient immune system is completely killed off, and it will take quite a while for the donor immune system to come back up. Patients will need transfusions periodically during the transplant procedure, and there is a risk for acute graft versus host disease, which I already explained is the immune reaction of the donor immune system against the recipient body, and which can occur about 20 to 60 days usually after a transplant. There's late toxicity, there's graft failure or mixed chimerism, meaning that sometimes the conditioning or chemotherapy that we give can be not intensive enough, so there's some autologous or own recipient stem cells surviving, and they will come back to repopulate the bone marrow, and sometimes the immune system, the recipient immune system, is able to get rid of the donor stem cells, resulting in what we call graft failure or rejection, or sometimes a state of so-called mixed chimerism, and we will come back to that a lot again later because it's important. So chimerism stands for the degree of donor cells within the recipient blood. So we could, for example, talk about a 100% donor chimerism, which is ideal because it means all the blood cells will be of donor origin, but it could also be mixed, like, for example, 50% donor, 50% recipient. And this can even differ between different cell lines, which especially in Wiskott transplants is very important to appreciate because it plays a significant role for the degree of disease correction. And I'll come back to that in a little while. GVHD can become chronic and happen also months and years after the transplant, which is a significant problem even though it is rare, but if it happens, it is a very bad complication that you would want to avoid at all costs. Infertility was also mentioned because the chemotherapy drugs can cause infertility. They don't necessarily do, but they can. Unfortunately, we don't have any numbers. We can't tell you how probable it is that someone would become infertile to the chemotherapy or not. We just don't know. There is no data. But we do know that it can affect fertility. Also, after transplant, there is still a risk for autoimmunity. This is mostly limited to ITP and autoimmune hemolytic anemia, especially in Wiskott, but it happens relatively frequently, but mostly does so in the first 2 years after the transplant. And we also observe that there is a tendency for this to kind of go away after a while. The conditioning itself also implies a slightly increased risk for cancer. So this is probably my most important slide for those who are not so familiar with the procedure because it kind of depicts the time course of a transplant procedure, starting with the decision to go to transplant and, of course, with a donor search. So once a donor is found, the pre-transplant phase or the garden planning will take place where the donor and the recipient undergo rigorous examinations to find out if they're really fit to receive the transplant or fit to donate and healthy. And then the patient will need a central venous line, some Hickman or Broviac catheter or something like that. This is actually a surgical procedure, but a very quick one. Then the proper inpatient transplant stay, which usually takes about 6 to 8 weeks. And this comprises 1 week of conditioning, which is right at the beginning, so the chemotherapy, and then immediately followed the next day or 2 days after by the transfusion of the donor stem cells, which if it is an unrelated donor, they are brought to us by a courier. If it is a sibling, they are taken in the operating room and then directly transferred to the transplant ward. After that, the patient will have to stay in isolation for about 3 weeks, meaning that he will have filtered air and will have to stay in his room, and the caregivers, nurses, doctors, parents, whoever, if they enter the room, they would wear gowns and mouthpieces, but these strategies differ a little from center to center. There is no firm recommendations for either. And this would also be, these 3 weeks would also be the time where the patient would experience the most acute toxicity, but then it will be followed by what we call engraftment, meaning that the stem cells of the donor have engrafted and there's the first sign of new blood cells in the blood. So the conditioning would be the plowing of the field, and then the transfusion would be the sowing of the seeds, and then a little later we would see small seedlings coming up, which is a very nice description because these are very sensitive still, and this is also true for the first donor blood cells that appear. This is followed by a quite intensive outpatient period, which lasts between 6 and 9 months, sometimes shorter, where patients are seen once or twice a week by a doctor, usually by the transplant unit, depending on the setting. And during this time, the patient will still take immunosuppressants and prophylactic antibiotics. He will be monitored for graft versus host disease, for infections, and also we will watch how his immune system slowly reconstitutes, meaning these seedlings slowly get better. After that period of time, if everything is fine, the patient will be transferred to long-term follow-up, which also differs between centers, but it's usually about yearly visits, where we mostly look for things like late effects. We monitor growth and puberty because hormonal replacement is something that may be necessary after transplant. And of course, we also look for fertility, which in males is much easier to monitor than in girls. So then, if everything's optimal, a beautiful and healthy garden will reappear. So I'm now switching over to what we know about transplant for WAS from a scientific standpoint. So when I entered the transplant field 20 years ago or so, these were the data that were available. Hi. And by that time, this was a study that was collected by the International Bone Marrow Transplant Registry and the NMDP. And by that time, they found that transplant for Wiskott from an HLA identical sibling or from a matched unrelated donor if the patient was less than 5 years old resulted in very good survival, while all other related donors, and this would mostly be mismatched family donors or haploidentical donors, or unrelated donors if the patient was older than 5, resulted in much worse outcome. The second larger study that was a little bit more up to date, that has been published in 2011, is also a collaboration of many large international centers and has, I think, close to 200 transplants. Yes, close to 200 transplants in it, and it shows that the outcome of the transplant improved over time. So the black curve is up to 1999, and the gray curve up here is patients after the year, transplanted after the year 2000, reflecting that there has been progress in the transplant field during that period, and I believe there's also progress being made after the year 2009, I think, when the data cutoff for this study was, but we don't have that published yet. One other interesting finding, or what this study could show again, that the outcome after matched sibling donors, so this is 5-year overall survival, was still very high, but there was still an improvement in any donor group over the years. And the interesting thing is that although these are very low numbers, so this is dangerous to compare, there seems to be an improvement also from mismatched related or mismatched family or haploidentical donors during that period. But what this study did very nicely, actually that would be the next slide. So this study also looked at whether the clinical score, WAS score of the patient mattered for transplant outcome, and it really does not. It also looked at age at transplantation, and they could show that children below the age of 5 do somewhat better than older children or older patients, and I will come back to that problem later. But what this study nicely also did, they also looked at late complications after transplant, which we should not forget, because we always look at those survival curves, and if a patient survives, we automatically assume that he's fine, which is not always the case, because patients after transplant may experience complications, and these complications are of different severity. We heard the patient before who spoke here, and he said he had some minor issues and otherwise he's fine, so that's okay. But there are other patients who experience severe complications, and these can be not only life-threatening, but they definitely can be very negative for their quality of life. So these are some of the possible complications that were looked at here. And what this study nicely shows that the incidence of the complication depends on the donor type, meaning while the overall survival is these days very similar, regardless of what donor we use, the degree of complications during and after the transplant differ. And the less well matched the donor, the higher the likelihood that we have any post-transplant complications, and I believe this is still true to this day. The other very important thing that this study looked at was the role of chimerism, meaning the degree of donor cells. And what they could show is that the so-called myeloid chimerism, so this is the cell lineage that is made of by the neutrophils and monocytes in our blood, is very important for the degree of platelet recovery, because the platelets also stem from this myeloid lineage. And so patients who have lower myeloid donor chimerism in the range of below 50% or something, they tend to have lower platelet counts, while patients with high myeloid donor chimerism usually have recovered normal or near to normal platelet counts. And the other thing that they seemingly showed is that the degree of chimerism also correlates with the incidence of post-transplant autoimmunity, but the correlation was not as strong as with the platelets and the myeloid chimerism. In this table, I have summarized some other studies, and I don't want you to read the entire table. I just wanted it to include it for completeness here and make the point that there are some smaller studies more recently published, and Dr. Thresher showed one of them that show very good overall survival data if these, but these are studies that stem from single centers, so it's kind of a selection there, but nevertheless they show that there's some very encouraging outcomes in recent years, and the field keeps on improving. The problem with these, all these published studies is that most of them were performed before the year 2010 or 2006, and many of them were performed with a conditioning of busulfan, which was previously available only as an oral drug, but since about 10 years ago was available as an IV drug, and cyclophosphamide, which is also something that is not used that often anymore for transplant conditioning. So the Inborn Errors Working Party of the European Group for Blood and Marrow Transplantation in 2005 published recommendations for transplant for primary immunodeficiencies, and they recommended either busulfan fludarabine or triosulfan fludarabine to be used as conditioning, and some centers also decided to some thiotepa. So what we did last year is we retrospectively looked at the transplant that were done in Europe with these two regimens, either busulfan fludarabine or triosulfan fludarabine plus minus thiotepa and serotherapy, in a very recent time frame, from 2006 to 2016. And we looked at all types of donors and all types of grafts. And for the sake of time, I cannot go into details, but we have almost 200 patients, which are relatively equally distributed between the groups, which is nice because it was a retrospective and not a prospective trial, so this could not be expected. And also the donor types and all the other characteristics are relatively evenly distributed. And in summary, we found that the overall survival is excellent with both types of conditioning, no matter what donor you use. I think this is, where's the donor here? This is the donor type. So you can see that the matched sibling donors still do the best, but then matched unrelated, mismatched unrelated, or mismatched family donors or haploidentical donors these days also have excellent survival rates. I need to go back here. Event-free survival, looking at either death or second procedure as an event. So I have to explain what I mean by that. So second procedure means that if after a transplant, for example, there is graft failure or rejection and the patient needs a second transplant, we would call that a second procedure. Or if the chimerism is not complete and the patient would receive a stem cell infusion, stem cell top-up, or a donor lymphocyte infusion, these would all be secondary cellular procedures to the patients. So this is different between the two groups. So what we could find is that after, it's not showing anyways, so that after triosulfan fludarabine, which is the blue curve, there's a higher incidence of secondary procedures in this group. And you can see down here what these were: second transplant, stem cell boosts, donor lymphocyte infusion, or sometimes splenectomy to correct the thrombocytopenia. So meaning that while both regimens result in the same overall correction of the disease, sometimes with triosulfan-based conditioning, it seems that there is a higher probability of mixed chimerism, and thus a higher probability that you would need a second procedure of some kind. This is also reflected in the chimerism, and I won't go into detail, but you can see that in the triosulfan arm there's just a higher incidence of less complete donor chimerism. I've already shown this, and I want to show this slide as well because it refers to the question, what is the optimal age at transplant? So this is a complicated curve. We did do an analysis where we compared survival in children less than 5 years and over 5 years, and there is a significant difference still. But if we look at this curve, the purple histogram depicts the number of transplants in this cohort, and this down here depicts the age at transplant. So you can see that the vast majority of transplants were carried out even before 3 years of age, while there were only very few transplants done after that. So that comparison is somewhat unfair. So what we did here is paint the relative hazard ratio of a transplant, and this is for survival. So, and this is a logarithmic scale also, and this line is the important line, meaning that the risk for transplant slowly goes up with age. But then when these down here, where there's only very few transplants, the statistical error becomes huge. So it's not really possible to say that these are valid data, but it looks like that the transplant risk somewhat increases with age and then jumps again with puberty, and then maybe even goes up more with adulthood, which is biologically what we think it does. But it's very hard to put it into scientific figures, and we've tried to do it this way. So in conclusion, transplant is curative these days in almost 80% of the patients, and about 90% of the patients survive regardless of donor type. And patients tend to have more mixed chimerism or graft failure after triosulfan than busulfan. And also, I haven't shown that, after haploidentical transplants, while the survival was still very good, the incidence of second procedures was actually very high in that group. And older age at transplant does remain a risk factor, but it is not possible to draw a line, like after this age it's impossible or it's not. Yes, all the haploidentical transplants were done either with in vivo T-cell depletion, meaning post-transplant cyclophosphamide, or with T-cell alpha-beta depletion. Lots of questions. So we'll just start over here.
I just wanted to confirm, can carriers either be a donor, a bone marrow donor, a peripheral donor, or donate her cord blood?
Yeah. I didn't address that questions for good reasons. There's actually, we don't have any data on that, and I'm not even sure we have a consensus about that among transplant physicians. My personal take would be, yes, we would accept a carrier as a matched sibling donor if he or she was if she was a perfect match, but if she had carrier symptoms, like for example lower platelet counts or other symptoms, and there would be a matched unrelated donor available, which was also a perfect match, I personally would go with the unrelated donor and not with the carrier donor.
That is for Wiskott or all next
Well, now they're throwing the curveballs at me. I think it's even more true in CGD. I don't know about ZIAP, for example, or XLP, or hyper IgM. I think it would be a case-by-case discussion.
Just one other question related to that. So what about a post-bone marrow transplantation? Could he be a donor?
Well, normally no. There are so-called domino transplants where patients who had undergone a transplant donated for their siblings, for example. And this can be done, but it's not clear whether that would be advantageous to either the recipient or the other donor. So I think the verdict's not clear on that.
Why would it not be advantageous?
If you do a transplant into another person, you will always repopulate the stem cell pool from a few million stem cells, but not the complete set or diversity of hematopoietic stem cells. So in theory, the repertoire of different stem cell clones could be limited in a stem cell recipient. So this could be of a negative impact for a further donor, but for further recipient of these cells. But that's just pure theory. It hasn't been researched at all.
Why are they still doing treosulfan versus
Well, I didn't. Thanks for that question. I didn't mention that for time reasons. But treosulfan seems to be seems to have less acute toxicity. We are pretty sure that it causes less mucositis. So many of the patients who undergo treosulfan fludarabine transplant do not experience severe mucositis as compared to busulfan. That's the main reason. So it seems to be less toxic in the short term. Whether it is also less toxic in the long term, we don't know. We hope, but we don't know. So these days, I think it's still completely valid to use treosulfan as a primary conditioning regimen, but you just need to be aware that it may cause more things to have to be done.
Right, because, I mean, we've heard of kind of a lot of chimerism going on, mainly related to treosulfan.
Yeah, but there's also the other side of the medal. I didn't show that curve, but if we look at the transplant-related mortality, which is the direct mortality from the transplant procedure, it is slightly higher in the busulfan group, meaning the chance to die from a complication of the conditioning right after the transplant is slightly higher in the busulfan group. On the other hand, all over, they stay the same because in the treosulfan group, more patients die after a second transplant, for example, because they need a second transplant.
Is there any data on post-transplant, like 10 years out, 15 years out, any of that, or no?
Unfortunately not. These studies are very difficult to carry out because we need the patients, we need that longer follow-up, which oftentimes we don't have, because if the patients are fine, they stop coming back to, usually the patients just stop coming back. They don't care, yeah, for good reason. Yeah.
Have they moved away from cyclophosphamide because of risk of sterility and malignancy?
Yeah, those are two of the reasons that we moved away from cyclophosphamide, although in all honesty, there has never been a direct comparison between fludarabine and cyclophosphamide in a control manner that I am aware of. I don't know if you do.
Certainly not in a controlled manner. In the primary deficiency treatment consortium, that is one of the factors that we're looking at in our retrospective study to try to see is it the same in terms of the outcome. And we didn't measure toxicity, but I think we all know just in the community that there's less toxicity in both acute and likely.
Yeah.
So my son is post-bone marrow transplant, and I would like to know if there are any tests to test his fertility.
Well, after puberty, yes.
Yeah.
You can just,
How far after puberty?
well, usually with about 16 years, he should be, you could start testing it if he wants it.
Is there anything besides getting sperm? Can you do a blood test?
No, it would have to be a sperm test. Yeah.
Dr. Albert, you mentioned with the donor types, a matched sibling donor, does that include both cord blood and bone marrow?
Yes, because most of the time we would use bone marrow from a matched sibling because very rarely we do have cord blood available, and if we do, sometimes it is of the cell numbers are not as good as we want them, so we would use bone marrow anyways. So most of the time that would be bone marrow, but it could be matched sibling cord blood as well if it's a good graft.
And in a perfect scenario, if we have enough cord blood and we also have marrow, is there a preference? You have it,
Well, there's the matched sibling donor, cord blood or marrow. If you have a perfect cord blood available,
You know, I asked this question, I asked this question to a bunch of other colleagues within PIDC when I had a patient where the family had collected their, the younger sister's cord blood, and I assumed, just like Dr. Albert said, that we wouldn't have enough cells. But it turned out we would have enough cells, which was just astounding, because usually don't have enough cells. So then we all discussed it. I think everybody voted on the side of using both. Because everybody said, well, the more cells, the better.
Yeah.
And at the same time, the bone marrow cells have the advantage that some of those T cells are going to have the capacity to fight viral infections, so you're kind of getting a little bit of viral immunity. But then maybe the cord blood T cells, because they're naive and inexperienced, that they would sort of have a calming effect in terms of graft versus host disease. So I think everybody kind of came down on the side of more cells the better, and maybe you can get the advantages of both by using both.
yeah.
Thank you.
What about the risk of replacing chemotherapy in humans?
Yeah.
How far is it?
It's a very good question whether we could replace chemotherapy with anything else. And yes, there are actually already clinical studies ongoing in other immunodeficiency SCID.
Can you explain a little bit what are the methods?
Well,
Prevention?
what's being used is antibodies that are directed against stem cell antigens, and these antibodies can either be pure or these antibodies can be coupled to either irradiation or chemotherapy agents, which would then go directly to the stem cells and kill them, sparing the rest of the body from the toxicity. And clearly these studies are very exciting, but the results are unfortunately very premature. And we're also not sure how these antibodies would come to the market unless a pharmaceutical company decides to bring them to the market. So it will be very difficult to implement this as an academic procedure. But that's clearly it is the future, I agree, but I can't say whether that will be 10 years from now or whether that would be 25 years from now. Yeah. In theory, that is immunologically possible, but I don't think you would do that, because if there's a matched sibling donor, you would use those stem cells only because they're the perfect stem cells. Any unrelated component would be inferior per se. So this was only what Dr. Pai said, was only referring to the rare occasion where we have a sibling cord blood frozen and the sibling in place, so we could draw some bone marrow from her or him as well.
Back to the fertility question. At what age would you recommend talking? I haven't spoken to my son now in fertility. Just wondering what the recommendation would be for talking about that and like giving your sperm and it's just really awkward.
Yeah. Again, there is no general recommendation, and I don't think there's even a medical recommendation. So as a father, and my son is 17, I would probably start to talk with him about that at age 16 or something, when it begins to matter. But I think it will very much depend on him whether he wants to talk about that at all or not, or postpone that talk until he's, 18 or 20, or not talk about it with you at all. Maybe talk about it to someone else. It's possible. All right, shall we continue? I think we will come back to many of those questions during the case discussions. Thanks.